Welcome, everybody. We are so excited to see that there's so much interest in this topic, one that we are all very passionate about, and hope to just provide some foundational knowledge with all of you so that you will understand the issue, and once you understand it, will most likely share in our passion. I'm Michelle Stiller-Bradley. I'm the Chief Program Officer at Wonderland Child and Family Services. I also am the parent of 4 children in a blended family, ages 12 to 24, one of whom has fetal alcohol spectrum disorder. So in my work at Wonderland and in the development of Hope Rising Clinic, I certainly have worn both hats through the whole process. I'm going to go over a few quick housekeeping things. One is that, yes, the webinar is being recorded. We will wrap up right at 1 o'clock out of respect for everybody's time. The last 15 minutes of the event there. Can you hear me now? Okay. All of a sudden I got a notice that I was muted, so we're good. Let's see. So please post your questions in the chat throughout the webinar, and we will get to them at the end. If you have any questions that we don't get to or ones that you think of later, please feel free to reach out to us. Also, if you want to see more content, this is just a little bit of a teaser, and my guess is some of you will be interested to learn more. So please reach out to us, and we'll be providing our contact information to find out about future webinars or trainings that we can provide. If you need any technical assistance, please put that in the chat. We have staff on standby to assist you with that. And before I dive into the topic and introduce our panelists, I want to give a quick shout out to our CEO, Mary Kirchhoff. Mary, could you just wave at everybody? The work that we do at Wonderland is hugely supported by her, and Hope Rising Clinic wouldn't have happened without her really wanting to understand the issue and becoming a champion for the issue. So thank you, Mary. I also would like to just do a shout out to Wonderland staff, Hope Rising Clinic staff, and any board members who are on the call. If you can all just turn your cameras on for a brief second and wave so people can see our team members. Thank you. Before I introduce the panelists, I want to introduce the topic. And first of all, I want to mention that prenatal substance exposure is really, really hard to hear about. It is a conversation stopper, not a starter in many situations. So we want to acknowledge that, and yet it's imperative that we talk about it and that we have these conversations. 1 in 10 kids has prenatal substance exposure. That's 5 times the prevalence of autism, yet we aren't talking about it. So that's what we're here to do. We're here to change that and move the needle so that we all are more comfortable talking about it. We don't want any shame or stigma around this issue. We just are here to really help children and families. And we want all of us to sort of have that same lens when we're thinking about this, that it's about helping the kids who are impacted by this and supporting the families. It's not about anything other than that. Why we started Hope Rising Clinic. There are multiple reasons, and I'm going to talk really fast because I have about 2 minutes. A few years ago, we started getting more referrals in our early support program for kids in the NICU who were identified as having prenatal substance exposure. Our provider team is very seasoned, many of whom are on this call right now. They were doing the evaluations as usual. They were providing supports and strategies as usual, and coming back to the table and saying, what we're doing isn't working as well with this population. What do we need to know to serve them better? And the evaluation tools weren't really capturing the nuanced challenges and delays that these kids were having. So we began conversations with experts in the field, starting with Susan Astley Hemingway, who then connected us to everybody and anybody who knows this work. And we developed a passion for this. We recognized it's a vastly underserved population. We also learned that often the challenges that kids have don't show up until later, after they've exited our early support programs. We've recognized a need to serve these kids who are older than 3 years old. So we developed Hope Rising Clinic. It is largely modeled based on parent-family voice. As a parent myself of a child with fetal alcohol spectrum disorder, I'm a member of many groups nationwide. And I really started taking note of what are families saying? What are they saying has been missing from services? What are they saying they need? And that was really top of mind in the development of what is Hope Rising Clinic. So now, without further ado, I will introduce you to our fabulous panel. We have Dr. Julia Bledsoe with us today. She's a pediatrician with the University of Washington, specializing in adoption medicine and FASD for over 22 years. She's part of the FASD diagnostic team at UW and part of Hope Rising Clinic. She is the co-author of Prenatal Alcohol and Drug Exposures in Adoption, and she is an adoptive parent herself. So we are very lucky to have Julie with us today. The next panelist is Jennifer Wisdahl. She is a policy advocate at FASD United, which is a national umbrella organization for many different chapters in various states. She also serves on the board of NOFAS Washington. She is a fierce and tireless advocate for improving and expanding services for children and adults with FASD. I honestly don't think she sleeps. She has 3 children who have fetal alcohol spectrum disorder, 2 of whom are teenagers and 1 who is just on the cusp of adolescence. So welcome, Jen. And we have Katherine Zintel with us today. As I was preparing for this introduction, I was remembering vividly, Katherine started with the clinic before our doors even opened. And I remember her putting together the sensory equipment that is currently in what we call our motor room. She has been a champion of prenatal substance exposure since the very beginning. She's developed a passion and a high level of expertise. She now is a mentor to the entire team. And watching her in action with the kids, she radiates joy. And she truly sees the little wins that these kids have, which is just critical to be able to do this kind of work. So welcome, Katherine. We're so happy to have you here. And I will be keeping time, so I may jump in. Excuse the rudeness if I jump in and give you a 2-minute warning. We're going to go ahead and turn it over to Dr. Julia Bledsoe, who's going to provide an overview on prenatal substance exposure's impact and treatment and intervention options. Thank you.
Thanks so much for the introduction, Michelle. And I'm just thrilled to be here. As you know, I could talk for hours, let alone 10 minutes, about this area that has become, again, just a wonderful part of my career and has brought so much passion and joy into that. I'm going to talk as much as I can in this short amount of time about prenatal substance exposure to give you an overview of its impact on children and the scope of the problem. Next slide. How big a problem is prenatal substance exposure? Well, we certainly know that even pre-pandemic, this was a growing challenge for children and for parents. From 2000 to 2018 alone, parental drug or alcohol use as a contributing factor for kids ending up in the child welfare system grew from 20 to 40%. What we do know also is that this problem has only become worse with the COVID pandemic. You can't open a newspaper or a news source without seeing these dramatic increases in substance use from even non-previous substance users due to the stress and coping with emotions of the COVID epidemic. We also know that opiate use and overdose deaths have increased 27% with COVID, which also adds to that pool of children who are exposed to substances in the womb. Next slide. I want to give you sort of a sense of how many children are affected by prenatal substance exposure. Michelle sort of alluded to a 1 in 10 child, and I want to put that in context for you when we look at other birth defects that children suffer from. Next slide. You can see here that on any given day, there are about 10,000 children, babies born in the United States. 3 of these babies will be born with muscular dystrophy, 4 born with HIV infection. 8 of these are born with spina bifida. 10 will be born with Down syndrome. 100 of these babies will be born with fetal alcohol spectrum disorder, and 300 of these babies are born with prenatal drug exposures. So even compared to childhood developmental disabilities, this issue is often overlooked, especially in light of the numbers that we see. Next slide. What do we know about prenatal substance exposure and its impact on the developing fetus's brain? Well, we do know from 40 years of research now that alcohol is the most damaging to the developing fetus, partly because it is what we call a teratogen. It disrupts normal brain formation as well as abnormal messaging within the brain. We also know that other drugs, even though they're not as damaging as alcohol, really can cause learning disabilities in children. Methamphetamine, we know, can cause disabilities. Opiate exposure, even though we have naturally occurring opiate receptors in our brains, it certainly can have an impact on the fetus, although not as profound as alcohol. Tobacco and marijuana, which of course marijuana use being on the rise in this country because of legalization, all of these can cause learning disabilities in children. This is just an overview slide that sort of shows you the impacts on children from prenatal substance exposure. And you see under some of the drugs, there's a question mark, partly because one, we just don't have good long-term studies yet on the impact of methamphetamine, but also because it can be very difficult to tease out what is causing what in a child who's exposed to multiple substances. Next slide. So what are the disabilities caused by prenatal alcohol and drug exposure? Well, the disabilities do vary from mild to severe. We do know, of course, that babies born to women who are abusing particularly opiates and methamphetamine, that we can see withdrawal syndromes in the newborn period. And while there can be a lot of focus on neonatal abstinence syndrome or infant withdrawal, really the effects in the newborn period are only the tip of the iceberg. The reason for that is that the part of the brain that is most affected by prenatal substance exposure is the prefrontal cortex, and as well as the limbic system and amygdala. And what those parts of the brain govern is higher order thinking, reining in of impulses, emotional regulation, sustained focus and attention, as well as memory and learning. So again, even though the newborn period gets a lot of focus, it really is kids over time that show us these disabilities and whether or not they're going to be mild, moderate, or severe. We also know that the disabilities caused by prenatal alcohol and drug exposure are lifelong. This is brain damage that doesn't go away. But we also know that there can be some things that mitigate the impact of that brain damage for children. Next slide. I will say, having been in this field for 22 years and at the clinic where fetal alcohol syndrome was first described, it is so true that the brain injuries in children with prenatal substance exposure have gone undiagnosed and unserved in our society. Next slide. Children with prenatal exposures have what I refer to as an invisible disability. And I do have permission to show these photos. On the right is a picture of a little girl with Down syndrome. And when people see a child with Down syndrome, because of their facial features, they know that this is a child at risk for learning disabilities. Next slide. But the face of a child with prenatal substance exposure, and this young lady has been through my clinic, has also been a patient of mine. Here she is being examined for fetal alcohol syndrome. No one would look at her face and know that she suffers profound disability from her prenatal substance exposure. Next page. I will just also say that I think the reason we really need to advocate so fiercely for these children is because they do have an invisible disability. What are the interventions that these children need? We know that most children with prenatal exposure would need intervention at every age of life. Every child will have different needs. If you think about the brain as a circuit board, depending what birth mom used and when, different wires will be clipped. So there's very different outcomes for each child. So they really do need tailored intervention. There's some generalizations, but really the impact on a child is really unique. Getting diagnosed and accessing interventions is very daunting for families due to lack of services, due to long queues for diagnostic teams, really a challenge for families and very stressful. Next page.
Julie, we're down to 2 minutes.
Great, I'm almost done. Why is access to diagnosis and services important? Well, we do know that early diagnosis and intervention for children with prenatal substance exposure throughout childhood and into adulthood prevents school failure, multiple trauma, including multiple placements in foster care. What happens to these children because no one knows, because their disabilities is so invisible, is that their behavior is caused by a disability, not by willful disobedience. And so for teachers to understand them, for employees to understand them is really crucial. We know that undiagnosed children with prenatal substance exposure get in trouble with the law. And all of us know that being incarcerated for developmental disability is just morally reprehensible. We also know that children that are not diagnosed are prone to mental health problems, anxiety and depression, and most importantly, they can perpetuate the cycle of substance abuse because their untreated disability can lead them to self-medicate with substances. So I hope that is a quick and dirty overview of a subject that I feel so passionately about, and I'm so grateful to the Wonderland team for creating a space for us to talk about this. Thank you very much.
Thank you, Julie. You definitely left us wanting more. I think most of us could listen to you for hours and glean so much from your knowledge. We are going to now turn it over to Jennifer Wisdahl, our next panelist.
Thank you, and thank you so much to Wonderland and Hope Rising Clinic for having me. I work on a national level on federal policy with the FASD United team, but I live in rural Pierce County, and I'm part of NOFAS Washington State, which is a grassroots advocacy and peer support nonprofit that gives referral and peer support to families of individuals diagnosed with a fetal alcohol spectrum disorder. So I'm going to talk to you a little bit about my own experience, and I will start this out by saying I do have the recent permission from my children to share their stories. This is something that I get regularly as part of Lessons in Consent. I was my son's 5th mom in as many years, and that was because his behaviors were so big. Foster families weren't able to handle or support him. Currently in the state of Washington, there is not really training on FASD or even really information given to foster families on FASD as part of their initial training. This is a bit of a surprise. If you look at the common training that foster parents receive, it's not there. It's not really, it's a tiny little mention. There is limited access to FASD-informed parenting support. Your standard parenting programs don't take into account the memory deficits and the cognitive disabilities that many of our children have as a result of their substance exposure. Once kids hit school age, then the trauma happens all over again because our school systems aren't prepared. With any of my 3 children, I have yet to meet a teacher that has any experience, knowledge, or training in supporting students with an FASD. FASD is not listed as part of the criteria for an IEP. You can get qualified under other health impairment, but there's no tracking mechanism for prenatal substance exposure or a fetal alcohol spectrum disorder within the special education process. Therefore, there is no focus placed on the distinct challenges that these students show in the school system. And because this doesn't fit neatly into a behavioral health silo, a mental health silo, a physical health silo, prenatal substance exposure really impacts all of those. It's very hard to get the resources in place through the existing infrastructures that we need. They go to school, their needs aren't always accommodated. mental health problems ensue. Finding counselors or therapists that are ready to wait until the child is regulated to be able to work on therapy. I know this is something that I've heard the Wonderland staff and the Hope Rising Clinic staff talk about, is waiting for readiness before approaching therapy with a child. That is very hard to find, and particularly within the rural areas of our state. It just does not exist. Having those lack of the supports, it extends trauma. Individuals with FASD or fetal alcohol spectrum disorders do not qualify for DDA unless their IQ is under 78. The majority of individuals with a fetal alcohol spectrum disorder have an average IQ. So we're not getting DDA support or any of the disability supports that other disabilities take for granted or automatically get. And FASD extends past childhood. My son, he couldn't read until the 5th grade. We were finally able, through the help of tutors and outside support, to get him reading and really get him to succeed in school. He did actually manage to graduate high school this last year during a pandemic with 100% remote schooling, and he actually qualified for honor roll. And we were so proud of him. My son has an IQ of 120. He went out to go get his very first job on the golf course and could not remember, he couldn't fill out the application because he could not remember his home address because of gaps in his short-term memory. He could not figure out how to translate the information off the resume that he so carefully prepared onto the job application because he has difficulty with transferring knowledge. These issues that he's going to have are lifelong, and we're going to be dealing with them for the rest of his life, as we're going to be parenting and being his external brain for the rest of his life and for my other 2 children. There was a study that came out a while ago that really compared the stress on families and caregivers of individuals with an FASD to that of combat veterans. Not having the resources, not having the support, not having the understanding and recognition within our existing infrastructures really does, it's hard. Looking at Washington state and policy for FASD, there is policy around diagnosis and providing funding for diagnosis. That having been said, there are 4 clinics in the state currently that provide diagnosis. Wait lists are large, and this is not accessible to many, particularly in rural areas. There is an interagency work group that is in code that hasn't met since 2017 because there's no funding for it. So there's no collaboration between agencies on what they can do for FASD. And federal reauthorization of CAPTA is going to be making some changes, and that is going to have an impact on plans of safe care and how prenatal substance exposure is handled. So just things to be aware of. Looking at some things that we could do as a state that are things that other states have been successful with. Down in California in particular right now, they're looking at adaptive skills as a measurement for disability services as opposed to IQ. And that's as a result of a major lawsuit in LA County. They're bringing in all kinds of training and support there as a result of that. Looking at listing, just getting an idea of where we're at with prenatal substance exposure within our school system by listing it as a distinct and separate category. Looking at non-punitive screening of all children entering foster care. We know that if we use screening as a punitive tool or a punitive measure, people aren't going to divulge that there was prenatal substance exposure. We also know that people don't intentionally set out to harm their developing child during pregnancy. That doesn't happen. So a good majority of the substance exposure, when it comes to alcohol at least, happens before recognition of pregnancy or with late recognition of pregnancy. So non-punitive screening is really important. Training for foster families. You know, this is something that many states are being very successful with, and that can cut down on the 5 placements my son had, the 3 my daughter had. My youngest only had 1, which is great. In training within the judicial system, our kids do tend to fall into difficulties with the judicial system. And so having their disability recognized within the judicial system, so we're not incarcerating people for a direct manifestation of their disability, I think is something to look at. Right now, there is federal legislation pending. It is in committee, the FASD Respect Act, which is bipartisan legislation introduced by Senator Lisa Murkowski of Alaska and Amy Klobuchar of Minnesota, and in the House by Alaska and Minnesota, respectively. It looks at FASD as a whole and gives funding to states to weave a thread of FASD understanding within their existing infrastructure. There's resources for training professionals that deals with a lot of these issues that I've talked about here. And if you'd like to find out more about that, I'd be happy to connect with you offline about it. And that's me. So I'll go ahead and turn it over to the next panelist.
Thank you so much, Jen. How you do it all, I'm not quite sure, but Jen has a hand in everything that's going on right now related to FASD, and your stories that you shared about your children are very powerful. Thank you. Just a reminder to attendees that we'll do some Q&A after Katherine does her presentation. So if you have questions, make sure you're posting them in the chat, and we'll circle back around after Katherine shares.
Thank you, Michelle. So again, my name is Katherine Zintel. I'm an occupational therapist at Hope Rising Clinic. I've been there since the beginning, and Michelle is correct. I did put up some therapy equipment, and I like to say that a little bit of blood, some sweat, and some tears were all put into that specific swing set. So before again, I want to give a shout out to the 39th District, yay, here in Sultan. Thank you, Representative Carolyn Eslick, for being here, taking time out of your busy schedule to hear about this. And just thanks to everybody who's here learning more about this really important, sometimes uncomfortable, but really, really moving topic. So what do we know? Okay, we just heard a bunch. Dr. Bledsoe talked about that medical and lifelong needs of children with prenatal substance exposures, with fetal alcohol spectrum disorders. Jennifer just gave a really powerful personal narrative about what it's like for some of her children and as caregivers. And we're left with this question of, what do we do then? What supports do we have? We know that there's these the PICS where our babies who are born addicted can go and receive support with that withdrawal system or with the withdrawal process, but then what? And I'm here to say we do have a program, it works, it's evidence-based, and I want to share that with you so that we can share that with others and kind of continue this work. So I'm ready for next slide. So Hope Rising Clinic for Prenatal Substance Exposure. Liz, you can keep clicking. There should be 2 more things. Thank you. Perfect. So I am part of a really amazing team. We have speech and language pathology, we have occupational therapy, we have mental health counseling, and we have family support specialists. And I'm not going to go through each of what all of our disciplines do. You can read through those and we probably know. But I do want to point out that it is amazing that we have one facility, one clinic that houses all of these disciplines. What Jen alluded to was that her kids have a lot of supports that they need. And what Dr. Bledsoe mentioned was that these are lifelong and they need to come from a lot of different areas. And I've heard from families how amazing and how stress reducing it is to have everything coming in one place with one team, one collaborative team. What I do want to kind of point out is within each of our disciplines, we have our scope of practice. We have those areas that we have our specific training in, but we all go above and beyond that and dig more into those challenges that Dr. Bledsoe is talking about within that prefrontal cortex. And I'll speak about it in just a minute, but we use a neurobehavioral model, which really guides what we're doing. So our speech therapists working on articulation, language development, receptive language, social skills. Oh, can you go back one more slide? Thank you, sorry. And in addition to that, taking it one step forward, what about our social skills? What about reading those nonverbal cues? What about how to explain what my body feels like when I am mad or excited? As an occupational therapist by training, I am a problem solver. We see occupations as those activities, those events, those roles, those jobs that give us a sense of meaning, a sense of purpose and joy. And I do that every day. And for kids, what is their occupation? Well, it's to be a student. It's to be a son or a daughter. It's to learn how to get myself ready in the morning to gain independence. I want to zip up my jacket so I can go outside and play with my friends. And so I work on that, but I also can't work on that until a child is regulated, until they can sit and attend and they're comfortable enough doing it, until they understand what the sequence steps are of putting on my clothes before I can even figure out if they have a gross motor or a fine motor delay. Then we have our mental health counseling, who is that, really go to identifying emotions, self-confidence, working through trauma, attachment work, really all of that kind of honing in on those really specific mental health needs. Something that is really amazing about Hope Rising Clinic is that every family has a family support specialist. And I see them as like the gatekeeper to any resource that a family could ever want. It can be any system that they're involved in, whether it is the school system for IEP needs, whether it's the medical system, finding a doctor who has a prenatal substance exposure lens, whether it is needing housing vouchers or food stamps, maybe it's respite care. It's even, we get a lot of families who are like, hey, I have a child who has some intense sensory needs, but I still want to get them into a ballet class. Or how can I go to a movie and find a movie theater that it has maybe some more sensory friendly showings? We get lots of different questions, and our family support specialists are there along every single step of the way. So really well-rounded there. All right, I'm ready for that slide now. Thank you. So that neurobehavioral model, what is it? Well, it's thinking about how the challenges that our clients see are based in brain differences, not willful choices. So neuro, brain, behavior. The brain drives that behavior. And that's really important when thinking about how I approach my clients and how I might write my goals and what my interventions look like. But it's just as important, actually probably more, in how I'm teaching and guiding my caregivers to support their kids. A lot of these interventions don't work. The typical parenting styles don't work as well for our kids, and helping caregivers develop that neurobehavioral lens really helps them shift their thinking of their child in order to support them. I'm ready. So what do? We provide services birth to 13 at Hope Rising Clinic. 100% of our clients have prenatal substance exposure. We're not the only clinic that sees kids with prenatal substance exposure, given the rate of 1 in 10. However, we are, as far as we know, the only one who really focuses only on kids with PSE. And that is because we think they need a special lens, and we want to support that. We provide services regardless of ability to pay. We all know about that insurance gap of what insurance reimburses and what it costs to provide services. So we do some fundraising. It doesn't cover the whole gap, but we never put that back onto families. They don't need another burden. We are very family centered, and I mean family and caregiver in every sense. I have birth parents, I have foster parents, I have adopted parents, I have grandparents, I have kinship, all of it. And we're all treated equally, regardless of whether you are foster, birth, adoptive, anything. So, and we provide trauma-informed care. Trauma in the pure sense, big T, little t, however you want to see it, but that's our approach. And then what do we have this kind of, where are we going? So we want to increase the number of evidence-based programs. And Michelle, I see I have 2 minutes. And so the CDC has identified 4 interventions that are evidence-based for the FASD population. We currently provide and implement 2 of them. We have training in all of them. And our goal for this 2022 is to provide at least 1 more of those. We're hoping to have all 4 by the end of the year, but we want to be reasonable. We want to, and we have plans to connect directly with birth parents who are recovering from addiction. The majority of our clients are in foster care or have been adopted, but we want to come back to birth parents too. So how can we reach those kids? How can we reach the birth parents specifically before they get to a point of having their children removed for addiction? And that is our next really big focus for 2022 also. And then the last thing is, we don't want to keep all this knowledge to ourselves. With the rates of it, with the needs, with the lack of just education that Jennifer was speaking to, we have plans to support other clinics in doing this, providing consultation, continuing these types of webinars, just really getting the word out so that we're not the only ones who feel like we are comfortable supporting this population. I'm ready for next step. So the last thing I wanted to leave you with was just first, thank you. And there's a website if you would like more information, but I have a really brief little short story. So my very, very first client at Hope Rising Clinic, this lovely little girl, she was 4. She actually had received early support services from Wonderland and transitioned then to our clinic. And we're in the motor room, we're on the swing set, we're in this really stretchy material, and I'm trying to help her understand her body and how her body kind of feels. And I slow it, with lots of bouncing and swinging, and I kind of slow it down and I look like, so how are you feeling right now? I don't know. Okay, well, how does your tummy feel? She's like, I don't know. Like, do you feel like you have butterflies in your tummy? And she looks at me very serious and she goes, Miss Katherine, I don't eat butterflies. And I learned a lot from that statement, and I ask my questions differently now. So thank you again, everybody. And I'll turn it back over to Michelle.
That is wonderful. Thank you so much, Katherine. Thank you to all of our panelists, such amazing information and from such different backgrounds and perspectives too. I am going to go over to the questions and I may call on some of our panelists to answer some of them, and I'm happy to jump in and share what I know as well. Let's see, the first question is if there have been conversations about FASD training with the Training Alliance. They do foster parent training. And it says, maybe there's someone from the Alliance at this meeting. Jen, do you happen to know if that connection has been made? If not, we certainly would look into it further.
Yeah, I think we need to look into that further.
Great. Okay, and that was Lori. And Lori, I know how to reach you, so I will follow up with you about that one. Let's see, we have another question here. Currently, most children born with prenatal substance exposure who are adopted are told by DCYF that their post-adoption support will be reduced to $100 per month or eliminated by age 5. However, many traits, symptoms of the physical, mental, emotional, behavioral difficulties don't make themselves obvious until pre or puberty years. How do we as adoptive parents advocate for the support these kids need throughout their childhood and adolescence? I will ask Julia Bledsoe to field this one, but we also have an amazing family advocate named Julie Gilo that if you want to put your email in the chat, I can connect you with her because she has raised more than 12 kids now with prenatal substance exposure and has dealt with a lot of issues similar to this. But Julie, do you have anything?
Yeah, I mean, quite frankly, that's just crazy. It doesn't match the science.
Right.
And we know that kids, IQ is not stable till between 7 and 8. That's the earliest we can really measure IQ or get a good look at learning disabilities that require higher order thinking. And we're not going to see that at 5. You can look pretty good at 5 and still be at risk for significant brain dysfunction. So I would love to have a contact to perhaps educate folks that are wanting to do that about the science behind this particular issue.
Thank you. I put my email in there. I also facilitate a support group in King County on Zoom every Monday for kinship caregivers. And I don't know, but one of them out of the group has a child who is not somehow affected by a parent's prenatal drug use. There's a couple of them that carry an autism diagnosis, but knowing the parents' behavior even today, I'd have a problem thinking they weren't using when they were pregnant.
Yeah.
So
thank you.
And the reason for age 5 is because your child goes to school full time and you no longer need daycare, supposedly, when they're 5.
Yeah, definitely something that needs to be addressed.
Well, and I can kind of speak to that a little bit too. Age 5, they're going to school. I am returning to the workforce now after 10 years of being away because I've needed to be there within 15 minutes of the school to be able to collect my kids when things go sideways. So the burden on families extends past age 5, particularly when the schools are not equipped to accommodate the kiddos. So what Dr. Bledsoe is saying is absolutely correct. And to add to that, we find that a lot of caregivers of individuals with prenatal substance exposure really are not able to work because they need to be there for their kids even when they're in the school system.
Yeah, they're on the family group sites that I'm a part of. I see many parents saying that the school, when they have trouble with the kids, will call the parents to come and get them. It's an automatic go-to. And so many of the parents, just like Jen was saying, cannot work because they continuously need to go and pick up their kids because the school can't or isn't equipped to really handle some of the challenging behaviors. It really falls to the parents still. Let's see, here's a question for you, Julie. Can FAS victims have unaffected children?
Absolutely. The brain damage done in fetal alcohol spectrum disorder is because of the use of alcohol during pregnancy. If you don't use alcohol during pregnancy, you will not produce a child with fetal alcohol syndrome.
Thank you. Next question. As someone currently studying to be a special education teacher and currently in a special education setting, what are some ways I can identify and support students who may have had prenatal substance exposure? And how do I build relationships with families, specifically when there may be some shame or fear or judgment with disclosing information that may be helpful for understanding and best supporting their child? Who would like to field this one?
I can speak a little bit on that. I mean, first thing is that likely there's not going to be any of those facial features like Dr. Bledsoe is saying. So it's that invisible disability. But I can speak to some of the commonalities that we see across kids with prenatal substance exposures. So things like motor delays, speech delays, those are less common. They do happen. This is why we have OTs and SLPs. The biggest challenges that I see are more in those executive functioning. So it's this emotional regulation, arousal regulation. So it's the kids who might be kind of set off for any reason. A little bit of rigidity about transitions often very black and white thinking, hence the butterfly. I don't eat butterflies, Miss Catherine. Like, why would it feel like there's butterflies in my stomach? I've never eaten one. Like, that's a ridiculous thing for me to ask. So that really black and white thinking. There's also incredibly frustrating, but there will be on days and off days, and it is so common. We talk about progress as peaks and valleys and plateaus, where we can one day and some days we just literally cannot. I can tie my shoe for 3 days and then suddenly I forgot how. And maybe it's a different shoe. Maybe I got a new pair of shoes and suddenly I can't figure out how to generalize that skill. In the academic setting, we see a lot of challenges with math. Seems to be really hard, and kind of organizing my space, organizing my writing to be an appropriate sizes and spacing. But again, we can have really average, above average IQ. So it can be kind of hit or miss about that too. And then the last thing I'll speak to, and then see if anybody else wants to join, but you know, when I work with parents who are birth parents, biological parents, in reflecting, I don't know how much differently I treat any of my parents, because I see it as you were bringing your child in to get the supports and services that you need. And so it's really non-judgmental. It's really also just making it clear, like, you know, these are challenges. It may be due to something that you know, a substance that you took before you even knew you were pregnant. And if we know kind of that background, if we have an idea of what type of substances may have been consumed, then we might be able to get the appropriate types of supports. At Hope Rising Clinic, well, obviously at Hope Rising Clinic, but in the Wonderland's early support program, we've just added that into our intake questions too. It's just kind of part of our intake, you know, what was your type of, you know, drug or alcohol use before you were pregnant? Did it change when you found out when you were pregnant? That's kind of my thought.
Nice, Catherine, thank you. I was reflecting on a personal experience for our family, and that reading was very challenging, learning to read for our son. I had helped teach 2 older kids to read and was really caught off guard by how difficult it was for our son. And what it came down to is his short-term memory is so impacted. And the way that kids learn to read is by starting with sight words, which is memorization. And so where my older children saw the word and they were able to memorize it, every time he saw the word for weeks, it was d. So it was extremely difficult until he was able to, so the level of repetition was just so great that was needed for him to really be able to grasp those words and utilize them in his reading. And when Catherine was talking to, I was thinking about a saying that the only consistency with these kids is inconsistency. And I remember hearing that several years ago, and it really is true. There are on days and off days. There are on minutes and off minutes. And so seeing that kind of roller coaster can be a sign of this particular disability. It is common to kids that have this.
Julia Bledsoe here. I just want to pop in there. Canada has developed some nice educational materials for parents. I mean, not for parents, for teachers who work with kids who are prenatally substance exposed. And I could certainly provide this group the link if they're interested in that.
Nice, that'd be great. Thank you. Okay, I'm going to go to the next question, which is also a Julie question. How much research has been done in the fathers being the alcohol exposure to the fetus?
Well, I don't want to say they're off the hook, but they are off the hook. I mean, we know that what the birth father contributes is sperm, but not the constant bathing of the fetus in alcohol, which is consumed by the mom. We do, however, know that addiction, just like heart disease and diabetes, can run in families. And so these are kids that their prenatal alcohol exposure makes them doubly vulnerable in that they were exposed to alcohol. They are more predisposed to have difficulty with alcoholism, and then they have a genetic predisposition as well. So these are kids we need to be very, particularly in adolescence, need to be very frank about that they may react differently to substance exposure. But in the womb, once the egg is fertilized, the birth father's role in prenatal alcohol exposure and damaging the fetus is done.
Thank you. The next question is, are there any future resources or training for kinship parents? We do not receive enough assistance or training as foster families do. And I do not know the answer to this one. Does anybody else know of any trainings available? We certainly could do it.
Yeah,
I your regional representative that for me it's a guy named Micah Kurtz that helped put out the trainings for the foster parents. If you have a kinship child, they will be happy to send you the information and let you attend for free to the webinars anyway. That's how I've been attending. I'm not a licensed foster parent. I've adopted one of my grandchildren and I am working on adopting the other one.
awesome. And I would also say there is a nonprofit that does provide training for parents and caregivers with for individuals with prenatal substance exposure. They have a full year's docket of trainings available from around the country, and it's the FASD Collaborative Project, fasdcollaborative.com. I know they have one coming up about for educators looking at FASD and education, but they have like I said, a full year's slate of training on different prenatal substance exposure topics available that are all free to attend, and there are certificates of completion with them, and in some cases credit that you can get as well.
Great, thank you. And certainly Hope Rising Clinic is happy to do any trainings. We do those frequently. We come out and talk to school districts, small groups, large groups. So we'd be happy to present to a kinship group. We'd love the opportunity.
Michelle, I'd like to jump in here just because I know there are some legislators on the line to say that whenever we talk about an increased need for services for a special population, this is a group that really is labor intensive. They thrive best from a multidisciplinary approach. And of course, you saw the Hope Rising as an example of the types of services. And I'll often get, the question, well, these types of programs are too expensive. And I just always want to remind people that prevention of those secondary disabilities from having prenatal substance exposure, like trouble with the law, school failure, those not only do they have a remarkable human cost, but they have a societal cost in terms of the number of these kids that end up in mental institutions or prisons. And there's a lot of work to be done in terms of managing these patients in those populations. So I just wanted to throw that out there because I didn't have a chance I'm grabbing more time.
I think you're muted, Michelle. We need at least one of those in a virtual event.
There's a follow-up in the chat. It's just a comment that any caregiver, including kinship, can attend trainings from the Alliance. And the Alliance was a group that was mentioned earlier. So that seems to be a good resource. Those are, oh, no, here's another question. Any good research on diet, vitamin, mineral deficiency, or medical support for this group that you can point us to? I think that would be a Julie question too. You're popular today, Julie.
Well, I hope I can answer it. One of the hallmarks of heavy prenatal alcohol exposure is growth deficiency. And so we're often seeing kids in clinic who are growing very poorly. And so sometimes we will need nutritional support in terms of working with a nutritionist and counseling. There's not a lot of research on after the fact when a baby's born, do they require any increased vitamins or minerals? I don't think there's any evidence at this time to suggest that. However, there's some very interesting emerging research on something called choline, which is one of the building blocks of neurotransmitters in the brain. And Dr. Ashley Hemingway, who's the director of our FAS clinic, has done some of the landmark research in looking at whether or not choline supplementation during pregnancy could help prevent or mitigate some of the damage done by prenatal alcohol exposure. But unfortunately, there's certainly not a magic vitamin to give people. We do know that the disabilities that these kids have, like ADHD, is actually ADHD and math disabilities are the two most common learning disabilities we see in prenatal substance exposure, alcohol and others. And we do know that they can respond as typical unexposed kids with ADHD would respond to medications. So we do have the medications that work for unexposed kids in our toolbox to use with this population as well, both the ADHD meds as well as medications for anxiety and depression.
Thank you. We are down to about 2 minutes, and there's one more question I want to get to before we wrap this up. The question is, how are you addressing the stigma to increase connection with biological and birth parents? And this is really important in our work, so I want to make sure that we talk about this briefly. What we have found is what you bring to the space is what is there and how it feels to the other person, and really making a shift, a mental shift, to where as a provider or as a professional, you come to the table without that judgment is key. Because if there's judgment, if there is blame, then moms are going to feel it. It just will be in the space. So it's really important to be able to shift gears, work through whatever that is, if there is some judgment that you feel, so that you can be completely present and open to work with birth parents. We are in the process of developing something called a parent-ally hybrid model that will, one staff member for that group will be what's called a parent ally, which is somebody who has had their children in dependency at some point, who is in recovery, so that they can help us connect to birth parents in a way that's more relatable and that feels safer. And there's been a lot of work in that area, particularly in King County and Snohomish County, that shows it's really effective. So we're really looking at who do we need to be as providers and who do we need to add to our team in order to really connect with these families. We also will be providing services that are brought to them where they are. So we have found that it is more difficult. When somebody's in recovery or in treatment, it is extremely difficult to get to a clinic for services. So we're really looking at what do we need to do? How do we need to shift our model to maybe meet with families in treatment facilities and in shelters for homelessness? So it's very, very important to the work that we're doing and to all of us. We also have added universal screening in our early support program. One of the things that happens with this is there's prejudice, there's judgment. And so only certain parents are often asked about their use during pregnancy. And that's across the board. That happens in doctors' offices. It happens in early support programs. It happens across the board, where if we suspect something, then maybe we'll ask. We got rid of that. We are asking all parents. This is an equal opportunity issue. This happens to all families. And so I think the more we all recognize that, that will help alleviate some of that shame and stigma and help us all connect more with birth parents that are really wanting help and support. So I'm going to wrap it up. If there's some other questions in chat, we'll do what we can to follow up after this. Here is a slide with our contact information. We would love to talk about this issue further. As I mentioned in the beginning, we're just barely touching the surface. There's so much more to share, and we would love to help add to everybody's knowledge. And hopefully we've sort of created the start of some advocates here who have attended that now realize how serious of an issue this is and how much work is yet to be done. And you certainly can reach out to us and find out how to get involved in the work too, if that is of interest to you and if this speaks to you. Thank you so much to everybody who came today. It really meant a lot to all of us to be able to share this work that we're also passionate about. Thank you.